That's horrible. Like, that's epilepticus is such a pre-arrest life threat CTAS 1. It's like 30 minutes, your brain's melted to scrambled eggs probably. Let's change it to 5 minutes.
Yeah.
Or so if you have one seizure lasting more than 5 minutes or two seizures without a full regain of consciousness, that's epilepticus. Life threat. And that's partially why I assume they add in the IO routes, because it's like, okay, if you're having that's a dire life threat potentially, right?
That's a really good point. So this patient was in status epilepticus when you showed up because they've been seizing that whole time. Absolutely.
Yeah. So it's like, oh, we need to do something now.
Yes.
And as you said, the longer you're in it, the worse outcomes, but also the longer you're in a seizure, the harder it may be to get them out of it.
So let's pivot. So we know that delaying benzos, underdosing benzos is really bad for your patient.
Mm-hmm.
So let's say in the prehospital setting, you have let's say this patient here that you treated. You gave 10 IM.
Yeah.
Okay. You got the seizure stopped for a few minutes.
Okay.
You did all your vitals. That's how you got all this stuff. Your 12 lead just shows AFib again. Now they're ventilating slightly better. You get an IV, but then they're never regaining consciousness.
Yep.
And 3 minutes later, they start having the same seizure presentation. What's your next step?
So are you ensuring that this patient's status epilepticus now?
Yeah.
When I was taught initially, because these are the guidelines, but it's changed, that status epilepticus is even having a seizure more than 30 minutes, or you've had 2 or more seizures without a full regain of consciousness. But they changed the guidelines. Is like, that's horrible. Like, status epilepticus is such a pre-arrest life threat CTAS 1. It's like 30 minutes, your brain's melted to scrambled eggs probably. Let's change it to 5 minutes.
Yeah.
Or so if you have one seizure lasting more than 5 minutes or 2 seizures without a full regain of consciousness, that's epilepticus. Life threat. And that's partially why I assume they add in the IO routes, because it's like, okay, if you're having that's a dire life threat potentially, right?
That's a really good point. So this patient was in status epilepticus when you showed up because they've been seizing that whole time. Absolutely.
Yeah. So it's like, oh, we need to do something now.
Yes.
And as you said, the longer you're in it, the worse outcomes, but also the longer you're in a seizure, the harder it may be to get them out of it.
Right. Which, why is that though?
It just becomes midazolam or benzos become less effective over time because all the acidosis and everything. But that doesn't mean they're not effective. Like, we may need a higher dose. We may need more doses. It all depends on the context and the patient again.
Right. So the affinity of the GABA receptor for midazolam decreases, right?
Yes.
So I think it'd be good to go over this because a lot of paramedics love to talk about this topic, but we know from, just neurophysiology, when the patient's seizing for a longer period of time, the benzos do become less effective. So people have talked about, giving ketamine because you're targeting the NMDA receptor to also hyperpolarize the cell and to decrease that resting membrane potential, right? So, paramedics have talked about doing this, and people would, they love this kind of treatment approach, but really, truthfully, we don't have enough evidence to make any sort of, recommendations or treatment guidelines based on that. Because currently the only evidence out there that's been published is case reports with very small sample sizes. They're done in the hospital. They're poorly controlled. It's really not what we're looking for when we want to inform clinical practice, right?
No, and people may be frustrated with this answer, but to give guidance on treatments, you need very rigorous, very robust, very replicable studies done again to say this is safe, this is effective, and ketamine for seizures is not there in the pre-hospital setting at this time, this year, at this place, and that's why it's not an option.
Yeah,
like they're very knowledgeable with the medicine and everything. They wouldn't withhold paramedics something for no reason.
Absolutely. So
what do we do?
We need a randomized controlled trial.
100%.
And probably the best way to formulate that is, so we know that ketamine, on a case report basis, has been able to stop these seizures. But there's no way to prove that it wasn't just like your benzos finally caught up, right? So you need a randomized controlled trial. You need to be comparing, probably a benzo only, a benzoketamine, and a ketamine only.
Yeah.
Some version of that. And we can talk about that in the future. Hopefully someone will do this out there.
Yeah.
But that's what we're going to need if we want to start it, including this in our practice.
What about the dose too? Is there a dose?
What dose would you use? Right now, it's all retrospective studies, right? So it's docs and centers just decided this is what we're going to do. And that's not something that we can replicate or provide guidance on, right?
And I always love this quote: subsequences don't mean consequences.
Yeah.
Like, it goes back to what you said. How do I know from these retrospective reviews that the midazolam I gave 20 minutes ago, if I just stopped and bound to enough GABA receptors to lead to a desired effect? Or maybe the patient just stopped seizing on their own. I cannot prove that one way or the other.
Yeah. So I think that's why you need to have some vials in your trucks that are going to be, unlabeled, and you enroll your patient, and you're going to give that vial after you've given your 2 doses of midaz, and we're going to be able to see with a large enough sample size to see, that placebo versus ketamine made a real difference, maybe not, but that's the only way we're going to be able to inform practice on it.
So what sample size would we need to change practice?
I can't do that calculation just in my brain right now, but it'd probably be between 500 and 1,000 patients in order to properly power that study.
And reproduce it again and again and again.
Yeah, it's going to, and you have to do it in a setting that's applicable to our clinical practice. So it would be a massive undertaking. I hope someone does it someday, but we'll see, I guess.
But it just shows the rigors of pre-hospital medicine and just medicine in general.
Yeah,
like, I'm not going to change practice until I safely and know thoroughly what the drug can and cannot do. So I appreciate that. But what do we do? If they're seizing and they're unresponsive to the first dose, if they're unresponsive to the second dose, what do I do?
Yeah. Currently, have that patch, have a conversation, and probably give some more benzo. I think would be the right option.
It's contextual, right?
Yeah.
What's going on? How much have you given? Again, if they've been seizing for a long period of time and they have less affinity to their GABA receptors, maybe we've been giving a suboptimal dose.
Yeah.
And I know people may be worried. It's like, well, won't that knock out their breathing? Won't that drop their blood pressure? And it's like, it may, but again, it goes back to your point, which is very accurate, saying there's not a lot of GABA receptors or benzodiazepine receptors in our brain center in comparison to our cerebral cortex. Is it a risk? Yes. Should we be cognizant of it? Of course, but they're still seizing, which we know is the true risk.
Yeah. And I mean, as paramedics, we're really good at managing ABCs. If they're hypotensive, we can treat that. We have fluids. We're going to have IV or IO access on these patients. If they're apneic, we manage apneic patients. Yeah, we can ventilate patients. We can, move with supraglottic airways and intubation. We can handle these things. But what we can't do is just leave our patients seizing, suffering from that glutamate toxicity that's killing their neurons. We can't do that.
That's key, right? Because they have excessive glutamate in their brains, which is a very excitatory neurotransmitter, which leads to this dysfunctional state. Maybe they have an abundance of those glutamate receptors amplifying everything, or maybe they have downregulation of GABA receptors, which we know would hyperpolarize and slow everything down.
Yeah.
Whether their electrolytes are out of whack, which they probably are from this incident history, everything's compounding on another. I was just looking at the colon CA. Are they receiving chemotherapy?
Yeah.
Or radiation? Are their neutrophils low, so now they have more prone to infection? Like, your brain's just bursting out. It's just like, those patients so complex.
Yeah.
I'm not going to figure this out in the pre-hospital setting.
No.
I can barely take a manual blood pressure. So it's just like, this guy needs to go to the hospital. Absolutely. We can't forget. It's like, we need to go to the hospital, but I need to treat the seizure. And the best quote I always think of it, there is no solution sometimes. There's this trade-off. Because, again, I have to stop the seizure, but what if I drop the blood pressure? Okay, what if you don't treat the seizure? What happens then?
Yeah. Yeah. We're going to, I think in general, have a bias towards action and, have that patch, have a discussion, have an informed risk-benefits conversation with that physician, and then see what we're going to do.
And I know maybe it's a barrier and it's one more thing to do on a busy call. But the reason why those patch points are there, or that ability to patch, is for those reasons. Like, say, let's get another opinion. Let's get someone that's a physician that's helping you weighing the risk and benefits and objectively analyzing the situation.
Yeah.
Maybe they're thinking about something that you didn't because you're just so caught up in the moment, which happens to any practitioner, right? That's why one of the best advice quotes I heard is, as a team lead, as a partner, it's just like, what am I missing? Because I'm not saying, what are you missing? It's like, what am I missing? Because maybe I've fallen into a bias, which is fine, but we have to recognize it.
Yeah. And, it's, I think, awesome that we're going towards like a consult kind of cash mentality where it's like, oh, I'm in the back of this ambulance on my own with a seizing patient that I've treated. I've given them everything I've got. I've maximized them as much as we can. My partner's driving. I'm not going to size my partner while they're trying to drive code 4 through a snowstorm. So I'm very happy to, get someone else on the phone and just have that open conversation. And, we can work together that way.
Imagine your cognitive load in that situation. The patient's not getting, I've given this. I've done the maps for this. The lights are dimmed. That's a loud sound. My partner's not here. This patient's severely complex. I'd just go sit down. I'm so tired, right? But that's the point. It's like, okay, I need help. I need to call a physician. Let's bounce some ideas off them to help this patient from a patient safety and adequate treatment.
Applying this to the pediatric context, like what are the nuances of treating this in pediatric patients?
That's always interesting. Like if they have a fever and they're having a febrile seizure.
I think that's an important topic to discuss for sure. Yeah.
So I've heard this a handful of times in my career. It's like, why would I give them a Midazolam for febrile seizure? Just cool them down. It's like, what if the febrile seizures from meningitis? You're not going to just cool that down.
No,
the life threat still is the seizure, regardless. Even though by the time you get to a febrile seizure, the vast majority of them are trivial. Not in the trivial sense that it's not a concern, but they don't lead to long-term negative consequences. But the vast majority of patients. But if you get there and they're still seizing, it's like, oh, we need to do something.
Absolutely, right? So, we know that an isolated event of febrile seizure in pediatrics is fairly common.
Yeah.
Viral season, we're going to do these calls pretty frequently, right? And we know that that's kind of the typical course with these. They have a witnessed seizure by their parents. They don't have a repeat seizure. And they're actually not at higher risk of developing epilepsy or anything like that later on in life, which is great. There's evidence to suggest that. But a certain subset of these patients are going to develop, more complex pathologies. One of them is FIRES, or febrile infection-related epilepsy syndrome, which is a new onset of status epilepticus. So we know that's very bad in patients without a history of seizures secondary to febrile illness. So just because you hear, oh, they have a temperature, they're febrile and they seize, that doesn't mean that patient can't be critically ill and need, aggressive management.
100%. Like never downplay a febrile seizure as being a benign event because you never know where it could lead to or what's the cause of the infection. Because there is a large genetic component to febrile seizures. Like if your parents had one or your sibling had one, you're at higher risk of them. But again, what if you have encephalopathy from an infection leading to a fever? We don't know that. What if you have a staph infection, strep infection, right? And again, what if it is leading to status epilepticus?
Yeah, we're going to have to treat them just as aggressively. It's just the same way, right? And I think that kind of pivots to the medication safety in this patient population, right? Because I think, correct me if I'm wrong, this is where we get those 10x drug errors, right? Is a seizing pediatric patient.
Well, just the optics. I got a seizing patient, and you probably start to, I'm speculating, but you're like, oh, I've seen 20 febrile seizures. I always get there and they're not seizing. Then you get there and they are still seizing. You're like, oh, I haven't mentally rehearsed or prepared for this. So you already feel behind the 8 ball and you're like, okay, what's their weight? And you do the pediatric math in your head and you draw it up and they're still seizing. Parents are screaming at you. It could be a very poorly lit house and everything. You can just see how everything's compounding and you accidentally drop 10 times X the amount.
Yeah, the holes in the Swiss cheese there are pretty big.
Yeah, then if you look at the system levels, did I use a Braslon tape? Did I confirm it? Do I have any ability to confirm this is the accurate dose? Did I check my medical directive books or apps? It's hard to say, right? It's hard to control the controllables in the pre-hospital setting under duress.
So that's why we have tools like the Braslon tape, like the PDStat app, and make sure you use those tools in these patients, right? We don't want to skip steps.
Yeah.
It's better to, wait that extra minute to really confirm these things and then give them medication. However, we definitely don't want to delay these medications, midazolam for pediatric patients either, because it's going to have all the effects we talked about previously. And we know that we can manage, the side effects of these medications when they're given at the correct doses, right? So don't be afraid of doing it, but we need to be cognizant of that.
Well, that's why I know we said this before, and I did this, like, let's say we got called to a 4-year-old seizure.
Yeah.
Right away, you just say, okay, I talked to my partner on the way. This is their approximate weight. This is my dose based on my medical directives. This is what I'm going to drop for midazolam. Does that make sense? I did map and look at the books. I'd use a calculator, look at the apps and everything. So I've already have a plan in place. Then the caveats, what if they're a different weight when you get there?
Yeah, exactly. There's always going to be that degree of, chaos that we have to deal with. Or, what if they're 8 and not 4?
It happens.
Yeah.
It happens.
Yeah.
But at least you're already trying to prepare it. This is just me. I would try to do one weight, the standard weight based on their calculations, maybe like a margin above, margin below. So I have a range to deal with.
Yeah.
And I just look at it.
Yeah.
That's what I
No, that makes sense. That's a really good tool. Good idea. So I guess again, what are the most common pitfalls or misconceptions paramedics they have when managing seizure calls?
most common pitfalls. It's a good question. I think it's hard, right? Because if you have somebody that's a head injury,
yeah,
their seizure threshold has been lowered dramatically. And that's a different pathology than somebody that's experiencing epilepsy, which we should probably get into as well. I think just maybe the paralysis by analysis, because we're notoriously good at that, paralysis by analysis, because that's how we were taught, which is fine. Like, you weigh all the risk and benefits. I want to be comprehensive. I want to be safe. I want to be thorough. But I feel like sometimes we just get too caught up in those moments and trying to analyze everything. I can give you a prime example that's kind of similar, but not. People always say, I'm not going to give glucagon. They don't have any glycogen stores. And it's like, well, how do you know that till you give it?
It's hard to tell just by looking at some.
I know. It's like, wow, you got no glycogen stores in your muscles or liver. I can tell. It's like,
Yeah, it's a really good example.
and then it's like, that's like me equivalent saying, oh, don't look like you got a lot of GABA receptors in that brain. And it's like, how do you know that?
Yeah.
Right? So I think we feel like we need abundance of answers and weighing the risk of benefits down to the nth degree. But sometimes you just got to take action. Sometimes you got to pull the trigger. Is it the best decision you made at the time? We can argue for the most part, yes, because it's what we knew at the time. I can't be biased because I don't know what's going to happen 10 minutes from now, but I did what I did at the time. I weighed the best risk and benefits I can, and I'm going to make a decision promptly and safely, thinking about patient safety. I think that's my personal view. What are the pitfalls? Because again, that's why they remove you have to take a blood sugar before doing a seizure, because we need to treat the seizure 100%. What do you think?
Yeah, I think I'll pivot away from kind of the critical care, critical illness side of this. One of the things that has become an option recently, and is, I think, a beautiful paradigm shift in our care, is the treat and refer pathway for patients that have a history of epilepsy, that have seizures often, that probably never wanted someone to call 911 for them. And now we're here. And our typical pathway for that would be, no, we have to take you to the hospital. You could die. Here's a code 72 that says you putting your life in your own hands. Right. And I know people trivialize this difference, but this treat and refer pathway is actually a huge difference, because we're actually going through the risk benefits for this patient. We're going through their history super in depth. How well is their seizure managed at home? Typically, if we didn't have to give them any benzos, no one else had to give them benzos. They had one seizure. We can leave those patients at home safely, right? And we have evidence to support that. That's why these are guidelines now. So I think that's something that, we could consider more often, right, in our practice.
Yeah, I love that. And just thinking 10 years ago, if you said this was a thing, people would probably scoff at you. And it is evidence-based. It's a super good addition that we've received. I'm just thinking from my health quality lens. Imagine 5 years ago, we were like, no, we need to take you to the hospital. And they're like, you're telling me my normal everyday epilepsy, I need to go to the hospital? And we look at them, and we're like, yeah, we could do blood work. We'd finally course them and be discharged within 10 seconds and say, go home. Is that patient-centered? Is that equitable? Is that effective, efficient, and timely? No. It's a waste. It's a waste to the patients and inconvenience. It's a waste to the staff of the hospital because, again, like if they want to go to the hospital, by all means, we're happy to take you. But if we have this paradigm shift to lead you home safely and effectively without having defensive medicine come into play, it's like that's an amazing option for them, and that's designed for the patient and for us.
Yeah.
It's a waste. It's less waste in the healthcare system, and it's more beneficial for the patient if they need it or want it.
And the more we use these tools, these treat and refer pathways, the more of them that can potentially come out, right, in the guidelines. And then we can really start to improve the efficiency of our system, I think. So,
yeah. Oh, yeah. And that's a huge expansion to paramedic practice and autonomy. At ADC, you see a patient that meets all this, you can safely leave that at home. You don't have to get them to sign up. You don't have to tell them for 5 minutes they're going to die.
Yeah.
It's like, no, you meet this medical directive. You don't have to sign my form because no refusal. You're going with my medical treatment. If you accept it, and I'll leave you at home safe. And if you have any problems, call back.
It's so much more realistic, right? Because when you're going out there as a practitioner and telling that patient, no, you're going to die. You need to get blood work. You need to get a CT scan, all these things to try to coerce them and go to the hospital. It's just not true, right? So we can earn that trust from those patients, from the public by, reflecting the reality of the situation, which is you have these on a weekly basis. And, we can have that conversation, risk benefit analysis together, let them drive that. And then, follow up with your family doc. Perfect. Have a great day.
Yeah. Right.
I think that's just so much more beneficial.
Patient-centered.
Yeah.
I'll keep hammering in this defensive paramedicine. Or defensive medicine. I'm sure you read the studies. I've had to learn a bunch of them. And I'm not saying don't tell patients the consequences. It's all in context. Tell the consequences that are relevant to the time and place. But whether it's in paramedicine or healthcare, defensive medicine leads to worse outcomes. It's more likely to be less safe, and it leads to billions of dollars of wastage. So that's why these directives have partially come into play. Patient-centered, more efficient, more effective, better.
Amazing. I think it's a really good place to end on.